Now, you take in case of the group A individual, you need to give a bronchodilator, right? Preferably, the muscarinic antagonist, they are being given then compared to that of the beta agonist. Because muscarinic antagonists are being found to be like more efficacious than compared to that of the beta agonist as a bronchodilator in COPD patients. Whereas in group B patients, we need to add a long-acting bronchodilator, right? That is either long-acting beta agonist or long-acting muscarinic antagonist, right? Whereas in group C, definitely it is your LAMA itself, that is long-acting muscarinic antagonist. And in group D, these group of patients, like we need to give a combination therapy, that is LABA plus LAMA, right? Long-acting beta agonist and long-acting muscarinic antagonist, right? And or the other combination is the inhaled corticosteroids plus long-acting beta agonist. But to which group of individuals you give this inhaled corticosteroids? You need to give inhaled corticosteroids in individuals if the eosinophil count is like more than 100, but preferably more than or equal to 300. So in them, you need to consider supplementation of this inhaled corticosteroids, right? This is about like different categories, like what are the drugs that you need to give. And there are two things in the treatment. One is dyspnea, the other one is exacerbation. So how will you like treat this dyspnea component? So the first and foremost, if the response to initial treatment is appropriate, then maintain it. If not, then you need to consider the predominant treatable trait to target, that is dyspnea or exacerbation, and use exacerbation pathway if both exacerbations and dyspnea need to be targeted, right? Exacerbation pathway. What is that you need to treat first? I'll discuss. Then place the patient in the box corresponding to the current treatment and follow the indications. Assess the response, adjust and review the medication. These recommendations do not depend on the ABCD assessment of the diagnosis. That is airway, breathing, circulation, not required. Now, so first important is the dyspnea component. So you need to give either LABA or LAMA. If with LABA or LAMA alone, I mean, when you are giving them separately, if the efficacy is not good, like if the symptoms are not improving, then you need to give combination therapy of LABA and as well as LAMA, right? Then when is that you need to add the inhalational corticosteroid therapies? The inhalational corticosteroid therapies, like we need to add mainly when there is increase in the eosinophil count, right? Increase in eosinophil count like more than 100. Then you need to add this inhalational corticosteroid therapy. Even with LABA and ICS, if the efficacy is not like good, if the dyspnea is still there, then you need to give a triple combination therapy of LABA, LAMA, and as well as the inhaled corticosteroids. But you are starting with what? Either LABA or LAMA. No improvement? Combine this LABA and LAMA, or ICS plus LABA. No improvement? Then the triple therapy should be given. Then what about for the exacerbations? Even for the exacerbations, you initially start with either LABA or LAMA, right? Then if the improvement is not there, then combine this LABA and as well as LAMA. Or if the eosinophil count in case of the exacerbation, if it is more than or equal to 300, then you need to combine LABA with inhaled corticosteroids, right? And in the first scenario, where you are combining LABA with LAMA, right, you need to consider the roflumilast if the eosinophil count is less than 100. But if the eosinophil count is like more than or equal to 100, then you need to give a triple combination therapy, that is LABA, LAMA, and as well as the inhaled corticosteroid therapy. And if the individual is a smoker, then you need to add the azithromycin, right? You need to add azithromycin. So this is about like the follow-up pharmacological treatment in a case of the dyspnea and as well as the exacerbations. And the next important is the role of the oxygen. So supplemental oxygen is the only pharmacological therapy demonstrated to unequivocally decrease mortality in patients with COPD. So the advantage of this supplemental oxygen is the only pharmacological therapy to demonstrate to decrease the mortality. That is the advantage of giving the oxygen therapy. And the use of the oxygen, like what are the indications for starting this oxygen? The indications for starting oxygen in patients with the COPD is if the patient is having resting hypoxemia, right, where the resting oxygen saturation, if it is less than or equal to 88%, right, less than 88% is, if the resting oxygen saturation is less than or equal to 88%, then we need to give the oxygen therapy, right? Or if the patient is having the saturation of less than or equal to 89%, along with that, there are signs of pulmonary hypertension, then also you need to give this oxygen therapy, right? Or because of the pulmonary hypertension, if the patient has developed the features of the right heart failure, then also you need to start the oxygen therapy, right? Or if the saturation is less than or equal to 89%, and then there is also erythrocytosis which has been developed, right? There is also erythrocytosis which has been developed, then also you need to start this oxygen therapy, right? And the usage of this oxygen has been demonstrated to have a significant impact on the mortality. Okay, so this oxygen, it has been found to reduce the mortality. All right, and patients meeting these criteria should be on continuous oxygen supplementation. Right, they should be on continuous oxygen supplementation, because the mortality benefit is proportional to the number of hours per day oxygen is being used, right? So if the number of hours of oxygen used, if it is more, then better will be the mortality benefit. Right, better will be the mortality benefit, more is the usage of the oxygen therapy. And for the administration of oxygen, there are various delivery systems that are being available. And these various delivery systems that are being available, they include portable symptoms or portable systems, right? They include portable systems that patients may carry to allow mobility outside the home, right? So these portable systems, by using them, the patient will not have any inconvenience of getting restricted only to the home or the hospital. They just can roam around with this portable oxygen therapy. The next important in the treatment in the genetic disorder related to your COPD, that is alpha-1 antitrypsin augmentation therapy. So let me discuss about this alpha-1 antitrypsin augmentation therapy, mainly in individuals with alpha-1 antitrypsin deficiency. So the specific treatment in the form of intravenous alpha-1 antitrypsin augmentation therapy is available for individuals with severe, right, with severe alpha-1 antitrypsin deficiency, right? And these blood-derived products, there is chance of, whenever you are administering this blood-derived products, there is chance of viral transmission, right? There is chance of transmission of this viral infection, right? So that is the reason why whenever you are giving these blood-derived products, you need to do the viral screening. And some physicians even recommend giving hepatitis B vaccination before administration of, right, administration of hepatitis B vaccination prior to right? Prior to starting augmentation therapy, that will be the specific treatment that you need to give in case of the alpha-1 antitrypsin deficiency. Like, along with this alpha-1 antitrypsin, you also need to give the hepatitis B vaccination, right? And in supplementing this alpha-1 antitrypsin augmentation therapy, it is being found that it can reduce the emphysema progression, right? It can reduce the progression of the emphysema. Now, who are the candidates in which you need to give alpha-1 antitrypsin augmentation therapy? So, in those individuals where the serum levels of alpha-1 antitrypsin, if it is less than 11 micromoles, or if it is nearly around 50 milligrams per deciliter, in them you need to give this alpha-1 antitrypsin augmentation therapy, right? And which category of the patients you need to give this alpha-1 antitrypsin patients? Because like we have PIZ, like we have M, then Z. So like among all these subtypes of the alpha-1 antitrypsin deficiency, the PIZ individuals, they will qualify, right? They will qualify the treatment for the alpha-1 antitrypsin deficiency, right? Because only a rare fraction of individuals with severe alpha-1 antitrypsin deficiency will develop COPD. This alpha-1 augmentation therapy is not recommended for severely alpha-1 antitrypsin deficiency persons, right? Only fraction of individuals with severe alpha-1 antitrypsin deficiency will develop the COPD. So that is the reason why all the patients, right? For all the patients with severe alpha-1 antitrypsin deficiency, the alpha-1 antitrypsin augmentation therapy right? It is not recommended. Right? For all the patient it is not recommended, right? And particularly for suppose, in spite of like severe alpha-1 antitrypsin deficiency, if the individual is having normal pulmonary function, right? If the individual is having the normal pulmonary function, in them, the alpha-1 antitrypsin augmentation therapy, it is not recommended. So that is about your alpha-1 antitrypsin therapy. Then followed by that, the non-pharmacological therapies. Patients with COPD should receive the influenza vaccine annually. Right? Should receive the influenza vaccine annually. Because these patients with COPD, like they are at increased risk of recurrent infections. And these recurrent infections include, like one is the influenza and the other one is pneumococcal vaccine. Right? Pneumococcal vaccine. And even vaccination for Bordetella pertussis. Right? So even vaccination for Bordetella pertussis, that is all in there being. So these three vaccinations have to be given in COPD patients because these three organisms are the one which can cause the infections in patients with COPD. Then the next important part of the treatment is the pulmonary rehabilitation, right? What is that we do in the pulmonary rehabilitation is, it refers to a comprehensive treatment program that incorporates exercise that incorporates education, that incorporates psychosocial counseling, and then nutritional counseling. Okay, so these are the one which are included in the pulmonary rehabilitation. And pulmonary rehabilitation has been demonstrated to improve the health related quality of life, right? It has been demonstrated to improve the quality of life. It has been demonstrated to improve the severity of the dyspnea. It has been demonstrated to improve the exercise capacity. Okay, so this will be advantage of the pulmonary rehabilitation. And it has also been shown to reduce the rates of hospitalization. Okay, so the requirement of the hospitalization, right? The requirement of hospitalization is also reduced by doing this pulmonary rehabilitation, right? And the next important treatment is lung volume reduction surgery. So, in a carefully selected patients with emphysema, surgery is done, right? Surgery is done mainly to remove, right? Mainly to remove most emphysematous portion of the lung. Right? Surgery is done to remove the most emphysematous portions of the lung, right? And by doing this lung volume reduction surgery, this will improve the exercise capacity, right? This will improve the lung function, and this will improve even the survival of the individual. That is the advantage of this lung volume reduction surgery, right? And the anatomical distribution of emphysema and post-rehabilitation exercise capacity, they are the important prognostic characteristic features, right? So important prognostic characteristic features are the anatomical distribution of emphysema and the post-rehabilitation exercise capacity of the individual. Now you take the anatomical distribution of emphysema. That will represent, that is one of the parameters which will decide the prognosis of the individual. So, patients with upper lobe predominant emphysema and a low post-rehabilitation exercise capacity, these are the group of individuals who will benefit, right? These are the group of individuals who will benefit from lung volume reduction surgery. And patients with FEV1 less than 20% of the predicted value and diffusely distributed emphysema on the CT scan, right? And diffusion capacity of the lung for carbon monoxide less than 20% of the predicted value. These group of individuals have been said to be having increased mortality after the procedure being done, right? So increased risk of mortality post procedure, and thus these individuals, they are not candidates, right? They are not candidates for lung volume reduction surgery, right? And methods of achieving lung volume reduction, right? Methods of achieving lung volume reduction by using bronchoscopic techniques have recently been approved by the US FDA. Okay, so you need to use bronchoscopic techniques, right? So bronchoscopic techniques have been used for achieving the lung volume reduction, right? And these bronchoscopic techniques which have been used for achieving this lung volume reduction, that has been appeared to be beneficial in selected emphysema patients, right? In selected emphysema patients, this bronchoscopic technically used lung volume reduction surgery was found to be beneficial. That is about your LVRS, lung volume reduction surgery. The next important is the lung transplantation. COPD is currently the second leading indication, right? Second leading indication for lung transplantation. And the current recommendations who can undergo this lung transplantation of the COPD patients, the current recommendations, they include very severe airflow obstruction, right? They should have very severe airflow obstruction. Number 2, severe disability despite medical management. Right? Severe disability despite medical management. So even in them, the lung transplantation is being recommended. And individuals who are having the comorbid conditions, right? Individuals having the comorbid conditions such as liver, renal, or the presence of a cardiac disease, right? So these are like the current recommendations or the candidates for the lung transplantation, right? Very severe airflow, individuals with very severe airflow obstruction, severe disability despite maximum medical management, and the individual should be free of these comorbid conditions. The individual should not be having this liver, renal, or the cardiac disease, right? They are the candidates saying you can go ahead with the lung transplantation. So this is about the non-pharmacological therapy. So apart from the cessation of smoking, the other important treatment options are surgical treatment options. So let me just quickly recap about the oxygen therapy, alpha-1 antitrypsin augmentation therapy, and surgical therapy. So what are the indications for the oxygen therapy? The indications is mainly in individuals with resting hypoxemia of less than 88% in any patient, or less than or equal to 89% with signs of pulmonary arterial hypertension, or less than or equal to 89% with right heart failure, less than or equal to 89% with erythrocytosis. Okay, so in them, the oxygen supplementation should be given. And this oxygen therapy in these patients have been found to decrease mortality in patients with the COPD, right? And this continuous oxygen supplementation, the mortality of the individual completely depends upon the number of hours the oxygen being used by the individual. More is the number of hours of the oxygen used by the individual, the mortality benefit is found to be good. And the various delivery systems are there, including the portable systems that will be very convenient for the patient to carry out even outside the home as well. And this alpha-1 antitrypsin augmentation therapy that is available for severe alpha-1 antitrypsin deficiency. Route of administration is IV. And it's a blood-derived product. So there is chance of the viral transmission. So hepatitis B vaccination supplementation prior to starting this augmentation therapy is very important, right? And this patients who are receiving this alpha-1 antitrypsin augmentation therapy, there is chance of reduction of the emphysema progression. And who are the candidates in whom you have to give? Where the serum alpha-1 antitrypsin levels are less than 11 micromoles or like around 50 milligrams per deciliter, in them you need to give this intravenous alpha-1 antitrypsin augmentation therapy. And that to which category of the alpha-1 antitrypsin deficiency? PIZ individuals. They will qualify for supplementing this alpha-1 antitrypsin, right? And these patients, all of the individuals with alpha-1 antitrypsin deficiency, you don't require to give this alpha-1 antitrypsin. Basically, it is not recommended for severe alpha-1 antitrypsin deficient person with normal pulmonary function, right? Only in individuals with severe alpha-1 antitrypsin deficiency with severe pulmonary dysfunction, in them you need to give this alpha-1 antitrypsin. Otherwise, if the individual is having normal pulmonary function, if the individual is having normal chest CT scan, in them, the supplementation of this alpha-1 antitrypsin is not recommended, right? And next is vaccination. So these patients, they are at increased risk of the vaccine, increased risk of infections. So they have to be given regularly the influenza vaccine annually, right? And then pneumococcal vaccination and vaccination for bordetella pertussis are being recommended. And if you take the another important pulmonary rehabilitation therapy, that incorporates like exercise, education, psychosocial, and as well as the nutritional counseling, right? And the advantage of this pulmonary rehabilitation is that will improve health-related quality of life, dyspnea, and exercise capacity. And that has been found to reduce the rates of hospitalization over 6 to 12 months period. Next is lung volume reduction surgery. This lung volume reduction surgery, this has been found to be very much useful in individuals with most emphysematous portion of the lung. And that will improve the exercise capacity, lung function, and as well as the survival of the individual. And this lung volume reduction surgery prognosis, it depends upon the anatomical distribution of emphysema and post-rehabilitation exercise capacity. And patients with upper lobe predominant emphysema and low post-rehabilitation exercise capacity, they are most likely to benefit from the lung volume reduction surgery. And the candidates with patients with FEV1 less than 20% of the predicted value, right? And diffusion capacity of the lung for carbon monoxide less than 20% of the predicted value, and the CT scan showing the diffuse emphysema, right? And the diffusion capacity is reduced. In them, the mortality rates have been found to be very high, so they are not the candidates for the lung volume reduction surgery, right? And even bronchoscopic technique of achieving the lung function, lung volume reduction also is very much beneficial in selected emphysema patients. Next is the lung transplantation. The COPD is currently the second leading indication for the lung transplantation. Right? The current recommendations for the lung transplantation, it should have very severe airflow obstruction, severe disability despite maximum medical therapy, and the individual should be free of the significant comorbid conditions such as liver, renal, or the cardiac disease. So this is about the treatment of COPD. The asthma symptoms or the asthma clinical features, they occur less than twice a week, right? They occur less than twice a week, okay? And what about night awakening? So, right, so what about night awakening? Night awakenings also will be there due to asthma. And this particular night awakenings due to asthma, they occur less than twice a month, right? Less than twice per month. And what about the FEV1, that is lung functions? So if you observed the lung functions, that is normal between the exacerbations, right? So between the exacerbations, the FEV1 is normal between the exacerbations. So that is what is the intermittent asthma, right? So the asthma symptoms occur less than twice a week. Night times awakenings due to asthma, they occur less than twice a month. Then the next, like what we have is mild persistent asthma. Mild persistent asthma is that the asthma symptoms occur more than twice a week, right? So the asthma symptoms, they occur more than twice a week, but not daily. And what about nighttime symptoms or nighttime awakening? Nighttime awakenings also will be present due to asthma, but these nighttime awakening occur more than twice per month, right? They occur more than twice a month, but not every day. Okay. And what about lung functions? Lung functions like FEV1, they will be normal between the exacerbations, right? So they remain normal between the exacerbations. So what was the difference between the intermittent and as well as mild persistent? That is the number of times. So in case of the intermittent, it was less than twice a week, that is asthma symptoms, and nighttime awakenings will be less than twice a month. Whereas in mild persistent, more than twice a week, and the nighttime awakenings, they occur more than twice a month. And FEV1 is normal between the exacerbations. Then we have the moderate persistent asthma. Moderate persistent asthma is that these patients, they have the daily symptoms of the asthma, right? They have daily asthma symptoms. And what about nighttime awakenings due to asthma? So if you observe the nighttime awakenings, right, due to asthma will be more than once a week, right? So nighttime awakening will be more than once a week, but not nightly. Okay. And what about FEV1? The FEV1, that is lung function, is reduced. So that is in moderate persistent asthma. Whereas if you observe the severe persistent asthma, here also there will be persistent symptoms throughout the day, right? The persistent symptoms throughout the day. And what about nighttime awakenings? Nighttime awakenings, they occur frequently, and there is limitation of the physical activity, right? There is limitation of the physical activity. And what will happen to the FEV1? The FEV1 is reduced. That is severe persistent asthma. And step 5 will be very severe persistent asthma. Here, the symptoms are continuous, right? The clinical features are continuous, and there is severe limitation of the physical activity, right? There is severe limitation of the physical activity, right? And what about the exacerbations? There will be even the frequent exacerbations as well, right? So frequent exacerbations, they do occur. And what about FEV1? The FEV1, it is severely reduced. That is what is your step 5, which is very severe persistent asthma. The last one is the refractory asthma. So refractory asthma is that where these individuals will have severe persistent symptoms, right? So these individuals will have the severe persistent symptoms despite the dose treatment and optimal management strategies. So despite the treatment, so in spite of the treatment, these individuals, they have severe persistent symptoms. Okay. So that is about your step 1, 2, 3, 4, 5, 6. Now, so I've just given you like what will be the features in step 1, 2, 3, 4, 5, 6. Let me tell you what is the treatment that you need to start with. So if you take the stepwise therapy, right? So first, the step therapy for treatment of asthma, this is for age 12 plus, which is modified for GINA, right? So GINA is the one which is being given by the World Health Organization, whereas your NAEPP, which is National Asthma Education and Prevention Program, is the guidelines by the United States. Now, these are the guidelines. So you need to address first and foremost the exposures and as well as comorbidities, which is very, very important. Then you need to confirm the inhaler technique and optimize the adherence. Then followed by that, you need to move up or down steps based on the control. So in this, like we have 4 things. One is, what is the regular therapy? Is it preferred or not? What is the alternative regular therapy? Then what is the adjunctive therapy? Then what is the reliever therapy as needed, right? As needed reliever therapy. So if you take in patients with step 1, they don't require any regular therapy. They don't require any alternative therapy. They require only just as needed reliever therapy. That includes the inhaled corticosteroids, right? or the LABA, that is formoterol, or the short-acting beta agonist, that is salbutamol or terbutaline. So only reliever therapy is required in step 1, whereas in step 2, usually they don't prefer for the regular therapy, right? Or you can add low-dose inhaled corticosteroids. The alternative therapy will be leukotriene receptor antagonist. And if you take the reliever therapy, yes, reliever therapy is required whenever there is like exacerbations, that is inhaled corticosteroids or the formoterol, right? Or concomitant inhaled corticosteroids and short-acting beta agonists should be added. So this will be your step 2 therapy. That is reliever therapy in step 2. Whereas in step 3, they will be requiring low-dose inhaled corticosteroids or the formoterol should be given. And the alternative therapy will be medium dose inhaled corticosteroids. The adjunctive therapy will be long-acting muscarinic antagonist, right? Long-acting muscarinic antagonist. And reliever therapy, the inhaled corticosteroids or formoterol in low dose should be given. That is in step 3. Whereas in step 4, you need to increase the dosage of the inhaled corticosteroids. That is, the medium dose inhaled corticosteroids are required, and the alternative regular therapy will be high dose inhaled corticosteroids. That is alternative regular therapy. Otherwise, the regular therapy is only moderate dose inhaled corticosteroids, right? And adjunctive therapy is the same like what I've discussed for step 3. Step 5, here we need to increase the dose of the inhaled corticosteroids. So basically in all of these, what is the very important is the intensification of the inhaled corticosteroid therapy is what I have discussed in the beginning also, right? Or long-acting beta agonist plus add-on long-acting muscarinic antagonist. And in step 5, the alternative therapies will be new molecules, that is omalizumab, that is anti-IgE, or mepolizumab, so that is anti-interleukin 5 or anti-interleukin 4R alpha are being added. And the adjunctive therapy will be similar to that of step 3 and as well as step 4. Whereas in step 6, the inhaled corticosteroids, they're not working here. In step 6, the regular therapy itself is anti-IgE or anti-interleukin 5 or anti-interleukin 4R alpha, right? And the alternative regular therapy, see, this is the preferred regular therapy. The alternative regular therapy will be the oral corticosteroids. Okay, so that is about stepwise treatment in patients with the bronchial asthma, right?